Hello, thank you for viewing this session on virtual crisis care, an innovative program being piloted in South Dakota to extend mental health care to places and times where it is most needed. I am Elizabeth Ruin, a program officer with the Helmsley Charitable Trust Rural Healthcare Program. My co-presenter is Barbara Pierce, the Director of Justice Initiatives with the Crime and Justice Institute. People living in rural communities face unique challenges in accessing timely mental health care. Compared to urban areas, rural areas have fewer behavioral health providers, more uninsured individuals, and have further distances to travel to access care. More than 60% of rural Americans live in mental health professional shortage areas. Suicide rates are higher in rural areas and are increasing at a faster rate than urban areas. The challenge of accessing care is compounded by the stigma associated with treatment. Nationwide, 1 in every 10 calls to law enforcement involves someone in a potential mental health crisis. In our rural communities that rely on volunteer first responder networks for medical emergencies, law enforcement is often the only responder to these calls. However, officers often do not have the resources at hand to most effectively help someone whose health and well-being are at stake due to mental illness. Co-responder models that partner law enforcement with mental health professionals, both in person and using telehealth technologies, have been successfully used in cities and counties across the United States. In 2019, South Dakota's most populated counties in-person co-responder model resulted in over 90% of people being diverted from emergency mental health hold or arrest. However, traditional in-person and telehealth co-responder models present a challenge for rural communities. If a rural community is fortunate enough to have an outpatient mental health service, asking one or a few providers to provide around-the-clock coverage is not ideal and may result in provider burnout. In rural areas, a response may be needed many miles from where the closest mental health professional is located. Thus, distance to provide in-person response is a challenge. Ideally, distance could be overcome using telehealth technologies. However, one person or agency providing 24/7 coverage for what may only be one crisis call a week or a month in a rural community is not cost effective. This map is showing counties with a designated mental health professional shortage area in South Dakota. The 4 stars I added to the map represent the locations of inpatient acute mental health beds. This map shows the challenges a rural state like South Dakota faces in providing mental health care, both with lack of providers and long travel times. When someone calls 911 for emergency services in rural America, an officer is likely the first person on the scene, and depending on the emergency, he or she may be the only responder. Because of this, rural officers more often find themselves responding to emergencies and crises than investigating lawbreakers. Although many people are aware of law enforcement's role in public safety, many people might not recognize the crucial role rural officers play in caring for people with physical and mental health conditions. Rural law enforcement officers seek out resources that allow them to better serve their communities. Equipping them to provide mental health crisis response services is an opportunity to expand access and will serve as a long-term asset in our rural communities. For crisis response to work in rural areas, we must evolve the co-responder model. The mental health workforce shortage and long distances between towns make typical in-person models challenging. Telehealth is key to bringing co-responder models to rural America. However, due to the low volume of calls, the current one mental health agency providing services to one law enforcement agency model is not practical. Utilizing one telehealth provider statewide creates an economy of scale. The same workforce pool can provide 24/7 coverage for all participating law enforcement agencies, which increases the volume of calls. This model is an effective and efficient way to provide mental health crisis response in rural areas. Virtual crisis care was established to mitigate the challenges of implementing traditional co-responder models while capitalizing on the resources available in a rural state. The goals of virtual crisis care are the same as traditional co-responder models: connect people to timely, appropriate care, reduce emergency mental illness holds, reduce unnecessary hospitalization, and very important in a rural state, reduce long transportation times. In addition, long-term goals for the program are statewide equal access, so no matter where you live in the state, you have access to mental health crisis response services, and have a mechanism for sustainability of the service. Before Barbara provides details on the virtual crisis care program, we would like to share a video.
Virtual Crisis Care is a program developed to assist law enforcement with safety planning and crisis intervention.
So that we're not having to try to act as a qualified mental health specialist out in the field.
Bridging the gap, so to speak, figuring out a way to get the people who need the care to the people who can provide that care.
Crisis response for law enforcement would be obviously responding to the initial call, whether that's from the person in the crisis or somebody else calling in.
10-4, I'll be en route to the welfare check, possible suicidal subject.
We don't make them feel like they're in custody, and so I think that reduces their stress level.
Summer, I appreciate you letting me in and you're willing to talk to me about this. You had a couple of friends that called in and they were a little worried about some of the things that you post on social media, that you may harm or hurt yourself.
My mother had cancer and she passed away. I didn't know it was going to be like this.
I know it would be traumatic and hard for anybody to go through. I do have a resource that will allow you to stay here. It takes just a couple of minutes, but it allows you to be able to talk to somebody that is, a professional that helps folks go through this. I have an iPad out in my patrol car, okay? Keeps you here at your home. Would you be willing to do that for me?
I'll try that. I'll do it.
It's always best to provide these individuals the proper care as soon as you possibly can.
It allows them to stay with their family, continue to work and do those things they need to do.
Because we don't want to be taking individuals in crisis to jails. You won't be making those hospital trips with every other cost that goes along with an evaluation there.
E-Care, this is Jacqueline.
Hi, Jacqueline. Deputy Chris Heislip with Pennington County Sheriff's Office.
Hi.
I'm here with a young lady named Summer.
She had a recent death in the family and having a hard time coping with that.
So She has agreed to speak with you.
The officer has a chance to tell the worker in Sioux Falls at Avera, okay, here's what we have here.
And your iPad name?
It is iPad 6, Pennington County 6.
Having that professional on the other end of the line to help them make that decision is a huge stress reliever for the officer on that decision-making process.
A lot of times for that process, it takes about an hour as opposed to tying up two officers 4 to 8 hours.
Hi, Jacqueline. Deputy Heislip here.
Hello.
I have Summer here at the table.
And then we hand that iPad to the person, and then we kind of back off.
Hi, Summer.
Hello.
My name is Jacqueline. I'm with E-Care. How are you doing?
Not too great. We buried my mother today. I don't know how I'm going to go through this tomorrow, and I don't know how I can go on, and I don't want to do this anymore.
Summer, I'm very sorry that you're going through this. What motivates you to stay alive?
What makes you happy?
That person is getting some sort of mental health help beyond law enforcement.
We are able to de-escalate the situation instead of having to handcuff them or bring them into jail. All right, Summer, is there anyone that you can call, anyone that can stay with you for a little bit?
I have an aunt, my Aunt Barbara, who lives a little ways away.
Your Aunt Barb supports you and you feel like she'd be someone good to stay with you? Okay, I think that'd be a good idea to call Aunt Barb to see if she can stay with you.
Have you been drinking anything or doing any drugs today?
I don't do drugs, but I did have something to drink when I got home.
It has 24-hour access from anywhere across the state. When we can use the iPads to connect them to a mental health professional, we can leave them at home and know that they're going to be connected to services.
And would you be okay if someone were to call you tomorrow to schedule a follow-up and to start counseling services?
All right. Well, that sounds like a plan, Summer. I hope you feel better.
And I hope you're the best, okay?
Thank you. All right.
We're saving thousands of dollars in man hours, but that's not what this program is about. This program is about helping people and bringing the care that they deserve to them at the time that they need it.
I'm optimistic that this program will continue to grow within South Dakota, and I also feel like we are setting the stage of what could be something adopted nationwide.
This is the best program that I've seen over the course of my career for offering people the help that they need.
So as Elizabeth explained in the video showed, Virtual Crisis Care is a pilot program that makes available behavioral health professionals to assist rural law enforcement in crisis situations. The program equips sheriff's deputies and police officers with tablets so they can connect a person in crisis with a behavioral health provider via a telehealth visit, wherever the person is at the time. This could be a person's home, in a sheriff's car, or in a parking lot, for example. The virtual crisis care service is provided by a single provider and is available 24/7. The provider helps with de-escalation, stabilization, and safety assessment. If safe to do so, the provider will create a safety plan with the person experiencing the crisis so he or she can remain at home rather than be transported to a hospital by law enforcement. After the telehealth visit on the tablet, and when the person is able to remain at home, law enforcement will help ensure the safety plan is put into effect. Also, in those instances where the individual is able to remain at home, a local community mental health center will follow up with the person. Cross-sector collaboration was key to the successful implementation of the virtual crisis care program in South Dakota. The pilot program is funded by Elizabeth's organization, the Helmsley Charitable Trust, the South Dakota Unified Judicial System, and my organization, the Crime and Justice Institute, provide implementation assistance, serve as the liaison with law enforcement and the provider, and are largely responsible for moving the pilot program to statewide implementation. The behavioral health service is provided by Avera eCare. Our primary community partners in this effort are the South Dakota Sheriff's Association and community mental health centers. The pilot sites include 18 sheriff's offices and probation in 1 judicial circuit. The counties shown in blue on the map represent sheriff's offices piloting the program. The counties in gray include sheriff's offices and areas where probation is using the program. And finally, the light blue shaded counties are areas where the program is only piloted by probation and not law enforcement. The pilot sites were selected for a number of reasons. We wanted counties of different sizes and that are different distances away from the state hospital. We also wanted different geographic areas covered, as well as some areas where cell service may be an issue. In these latter communities, it was especially important that we test the virtual crisis care technology in different parts of the county. We also worked with the Sheriff's Association to select a variety of sheriffs who are seen as leaders within the state, who have a particular interest in mental health, or had expressed concerns about the challenges associated with emergency mental illness holds in their counties. Let's take a quick look at some of the virtual crisis care data. Nearly 2/3 of the virtual crisis care encounters involve men. And as the pie chart shows, the largest proportion of encounters are with people ages 25 to 44. Elizabeth noted earlier that stigma associated with accessing mental health care is a major issue for those who live in rural communities. It is the people in this 25 to 44 age group who are most likely to know the local mental health provider. It could be their neighbor, and their children may go to school together. In a moment of crisis, when you may be having your worst day, you may find comfort in the anonymity of talking with someone who will not see you at the grocery store the next day. The ability to access a provider who does not live in the same community through virtual crisis care can help reduce stigma associated with getting care. In terms of the times of day, 65% of virtual crisis care encounters occur between 5 p.m. and 9 a.m. This is an important statistic given the behavioral health workforce shortages in rural areas. Many local mental health care providers work 8 a.m. to 5 p.m. If they need to provide 24/7 coverage, they may burn out over time. Virtual crisis care can avert the need for these professionals to be called out evenings and overnight. Another issue is that it can be costly to pay behavioral health staff to be available 24/7. And in rural areas, these crisis calls may happen very infrequently. Having a single virtual crisis care service provider can reduce or eliminate the need for 24/7 staff in these rural communities. The pie chart shows the main reasons for virtual crisis care and why it's been used to date. The dark blue part of the pie shows that suicidal ideation accounts for over 4 out of every 10 encounters. Depression is the next most common reason for virtual crisis care is used. As we mentioned earlier, a primary goal of virtual crisis care is to avert unnecessary involuntary mental health commitments. The pie chart shows that people are able to remain at home or in place 74% of the time, and another 6% voluntarily admit themselves to a hospital. This means that we avert involuntary hospitalization 80% of the time. Case studies with a sample of the pilot sites in South Dakota, law enforcement placing a person on an emergency mental illness hold can cost counties between $950 and $2,700. These costs include law enforcement time on scene and transporting people to a hospital, mileage costs for transports, legal costs associated with the commitment process, qualified mental health professional evaluations, and the state hospital admission fee. Once a person is admitted to a state hospital, the state covers the cost of the inpatient hospitalization at over $800 a day. When involuntary commitment can be avoided, the costs are much lower. The cost of virtual crisis care service is about $250 per encounter, and counties can cover just officer time on scene, which on average can be between $27 and $108. Another benefit of avoiding involuntary commitments is that law enforcement officers are able to remain in their communities to address public safety concerns rather than driving sometimes 5 or 6 hours one way to the state hospital. I will now turn it over to Elizabeth to wrap up.
Thank you, Barbara. The Helmsley Charitable Trust provided $1 million in funding for the initial virtual crisis care pilot period. This past year, the Unified Judicial System successfully secured state funding to continue the pilot program within the current counties and expand the program to another 6 law enforcement agencies. The goal over the next year is to continue to demonstrate the value of virtual crisis care so that it is funded statewide as part of the South Dakota Continuum of Crisis Response Services. It will cost an estimated $580,000 to achieve this goal. This would allow for 24/7 provider coverage in all areas where in-person mobile crisis teams are not available in South Dakota. The $580,000 annually translates into 92 cents for every South Dakota resident per year. We think this is a worthwhile investment. It would mean every person in South Dakota would have equal access to crisis care by a mental health professional at the time and place it is most needed. Thank you for joining us to learn about virtual crisis care, a program that has shown through innovation and collaboration we can increase access to mental health crisis care in rural communities. This is a model we believe could prove effective in other rural states as well. Please reach out to Barbara or myself with any questions. Thank you.